Hi guys, in today's case we're going to go through a spaced case, so someone who's got gaps top and bottom, multiple diastemas, and my thought process behind the treatment and the massive side effects-ish that you can get when you're closing gaps and how I manage that. So I hope you enjoy it. Here we go.
Okay, guys, so this is the case. This is my friend Ollie, and he's the one with a YouTube channel and all that. So I'll just show you his before and after photos. So this is where we started, was here. He didn't like the gap between his teeth or all these gaps between the lower teeth, and this is where we finished. And all I did was just a bit of ortho. So let me talk you through the case right now. Let's find his pre-op photos. So smile shot a little bit closer up, we can see what's going on. We can see a massive diastema there. Really, probably a little. Initially, I thought, no, this is way too big to close with just braces. So we had options of bonding and possibly veneers in the background as well. But you can see from the side that we got a bit of bimaxillary proclination going on, which means that if we just upright the teeth, we're going to reduce some of the spacing there anyway. So that's positive. And from the occlusal shots, you can see there's a bit of spacing towards the back here. So what the discussion I had with him was, we can close all this spacing up at the front, but we're probably going to have a bit more spacing at the back if we're going down the route of just ortho. And this here, I thought it was caries, but I took an X-ray and it's actually okay. And similar story at the bottom, all proclined. There's basically the teeth are not big enough for the jaws, but we can attempt to just tip them back a little bit, see what spacing we're left with, maybe look at some kind of composite bonding there as well, but eventually just end up with spaces a little bit further back. So if we just go into a bit more detail on the occlusal shots, what I was aiming to do was, let's look at the bottom ones first. We're going to actually move these teeth all in a little bit. So right now the incisal edges are there. We want the new incisal edge to be a little bit further back. And I didn't do a Kesling setup or anything like that, so I wasn't sure whether we're going to actually close all the spaces in between the teeth. My honest gut feeling was I didn't think that we'd be able to. But I did know we were going to end up with some spacing a bit further back, maybe behind the canines or the in between the premolars. So he was happy with that, and we just moved forward. So we got the brace on. So my technique here is, if I'm sort of retroclining the teeth, and we've got a brace on, it can actually take ages. Excuse me. So if we're in like a stainless steel wire like this one is, then you put the power chain over the top, you're expecting the wire to just poke out further from the back, and this can take ages because there's a lot of friction involved through all the teeth and all the brackets that it's got to slide through. So what I've done here is tied together here and here with a long tie. Okay, so these three teeth on both sides are just like linked together, so nothing's going to move there. Then I've got the power chain on from here to here, and that's almost independent of the teeth. So the power chain goes on the brackets, and that directly pulls these guys in a little bit, and then the power chain wants to be here, so all these teeth just get tipped back. So this is quite a quick way of doing it, but it is a bit unpredictable, so you've got to really keep an eye on things and what's happening. And the wire, you can see, isn't engaged in the bracket, so I haven't got any legs, any donuts on any of these brackets here. And you tell the patient that, look, I'm expecting the wire to come away from the teeth, and I think I saw him every 2 weeks or something like that. Now, when you're closing these gaps up, for the top teeth, I think it was just power chain from 2 to 2 initially, then 1 to 1, and then 2 to 2, and then 3 to 3. Just a normal kind of pattern, nothing too new going on at the top. But when you do this, you get a lot of this clumping up of the gum in between the teeth. So this is what he looked like at the end of treatment, and all the tooth morphology is completely changed. And I knew that the gaps had closed because you can floss through all of this and you can feel the contact points, but we've got way too much gum in between the teeth, and the teeth look absolutely terrible. So the way we fix this is I used a soft tissue laser just to recontour the teeth at the CEJ, so you can do what do you call it? You can do all your your soft tissue probing and make sure that you're at the CEJ, and then you can see and then recontour the bottom of the teeth as well. And then that was a little bit long there. And you can suddenly start to see that, you know, once you do all of that, it's not going to look too bad, which is exactly what we did. Here, this is the photo I've just shown you, and lower, I don't know why I've taken it at such a weird angle, but here. So this is immediately after doing all the laser work, and you can see I've just followed what I think the tooth should look like, and we're just exposing a lot of the natural tooth there. But in areas like this and right in between here, you have to actually go over this area of the gum and just thin that out as well, so you don't have like a massive bulbosity here, and that's why this looks like it's had a lot of work done to it. Similar story at the bottom, just do exactly the same thing. Get these nice sharp papillae because they look really, really nice. And then just let it heal. Now this looks really bad. It looks so painful, but he said this really wasn't that bad. It was a bit sore the day after, but that's about it. So we left it a couple of weeks, and it wasn't quite long enough, but I think maybe a week or 2 weeks, something like that. You can see where we did a lot of lasering, it's still healing there, but it looks a million times better. That's the full top. And then even the bottom, a little bit of healing going on at the bottom, but we're almost there. So that's, you know, a really neat way to finish off the smile. We always need a bit of enamel contouring, but the gingival contouring can make a massive, massive difference at the end of the case. So he was happy. You can see his smile's a lot wider. He's showing a lot of gum when he smiles, and he's not bothered about the gaps behind the canines or anything like that. So, hope you find it useful. Any questions, comments, you can just write them below, and I'll try and get back to everyone. Great, so I hope you enjoyed that. If you're new to cosmetic dentistry, or maybe you just want to do more of it, then it's pretty well regarded that having good photography skills is essential. If you think your photography skills need to be improved or brushed up, what I've done is put together a free online course for you. It's about 6 or 7 video lectures plus handouts and stuff like that, where I just explain how I use the camera in my practice. I'll show you what gear to get and all of that as well, and I'll show you how I manage my photo portfolio. On a normal day, I'm probably taking between 10 and 100 photos, so there needs to be good systems to manage your photos and back it all up, and then right at the end I'll show you how I use my photos to increase the case acceptance. So if you want to get access to this video, all you need to do is click on the link. I'll put it in the comments below, and it will take you to a page. Just sign up for it and work your way through it. I hope you enjoy it. Take care.